Introducing the next generation of 3D tomosynthesis from Cubtech, delivering crystal clear, high-quality 3D images with the precision of amorphous selenium direct capture. A large, active imaging area ensures no detail is missed, and seamless integration with Gamma Pro streamlines your workflow. Studies show the Mozart system can reduce re-excisions by up to 50%, while preserving healthy tissue for better cosmetic outcomes. The result? Improved surgical efficiency and quality of care for patients.
When it comes to specimen imaging, there's only one name you need to know. It's Cubtech.
Welcome back to the Mood Food Podcast. Today, we are completing this journey by going back to where it all begins, detection and diagnosis. I'm honored to be joined by Dr. Puja Sharma, a leading breast radiologist who plays a critical role in identifying breast cancer early, guiding biopsies, and helping shape each patient's treatment plan. This conversation will take us through the entire patient journey, from screening and detection to treatment planning, surgery support, and survivorship. Whether you're a patient, a family member, or someone simply wanting to understand more during Breast Cancer Awareness Month, this episode is for you. Can you share what inspired you to become a breast radiologist and what your role entails in a patient's cancer journey?
So I actually, when I had gone for my first rotation in breast imaging when I was a radiology resident, I was really amazed at a lot of my female doctor mentors. And that really inspired me initially when I was a resident. And I just saw how compassionate they were towards these patients who were coming in with a lot of anxiety because it was a very sensitive part of a woman's body. And, there's a lot of media focus on breast cancer these days. So a lot of people were coming in with a lot of anxiety about this. And I just saw how compassionate my mentors were towards these women and answering their questions and providing care to them. And that was another thing that I saw that was unique in this field of radiology because usually as a radiologist, we don't get to talk to patients. And we're kind of sitting behind a screen on a computer. And, you might see a radiologist name on the report, but you never actually get to meet them or know who they are. But in breast imaging, because we actually get to talk to our patients and we perform procedures and biopsies, we get a little bit more hands-on experience with our patients, which is something that I really liked as well.
So that's what's different about a breast radiologist as opposed to a radiologist that, is looking at other people or other diseases essentially.
Yes, definitely. And so the breast radiologist also plays a key role in, I would say, the beginning of the diagnosis. So our job, our role as breast imagers is to find suspicious lesions or to find the breast cancers on different types of imaging modalities. And most of the time, we're also the ones that perform the biopsies, the procedures to help diagnose. And we also give the news to patients who are hearing for the first time that they have a breast cancer.
Interesting. So do you get trained to do that, to actually give the news?
We do get time, during our fellowship when we're specifically um, like studying how to be a breast imager. We do get time and some practice with how to very kind of considerately and carefully give that news.
Yeah, because it's such an emotional moment for someone who hears something like that. And you kind of have to walk them through that, right?
Yes, of course. I think it's always helpful if the patient knows the person who's giving the news. So generally, if I'm going to be calling somebody to give them the results, I would probably be the one who talked to them before, during the procedure, the biopsy. I would let them know, more about the results and answer any questions. And then the call is always the follow up part. But I think everybody deals with news differently, and there's no right or wrong way to handle a situation. But I always just try to reassure, every patient once, they get the news that it's breast cancer, that a lot of times it's a very, very treatable condition and they're in good hands. And, we help navigate them to the next step.
Go ahead, Doctor.
I had a sort of a quick question. The fact that a patient sees their general practitioner or their internal medicine doctor who says, I think you need to go to a radiologist and have this checked out. Whereupon they come in, you see something, and you do the biopsy there and then, correct?
So it depends what it is. When a patient comes in, they can present for, sometimes it's an area that they're feeling, like a lump. And we do the additional imaging first, and we try to see, is this something suspicious? If it's not suspicious, we might decide, either they can return for a screening exam in a year, or they can come back in a short interval, which we usually do a 6-month follow up. Those are for things that are probably benign. And if it is suspicious, then we would definitely schedule them for a biopsy. But some people present with other things, like they can present with pain. And sometimes pain can be from, benign things like cysts. Sometimes it can be from more suspicious things. And sometimes it's just a normal part of a woman's monthly cycle. And, I think doctors get a little nervous. So, um, if a patient comes in who has like breast pain with their, period every month and it goes away after that, normally you would just need to reassure a patient. But I always encourage people to come in for screening or for imaging if there's any doubts, for sure.
But if you did see something suspicious, would you do the um, core biopsy at that point, or how would you
Or
proceed?
is that another, they come back another time for that?
So I would say if there is a suspicious finding, there's different types of biopsies. There's the core biopsy, which is an ultrasound guided biopsy, and then there's a stereotactic biopsy, which is a mammogram biopsy. And there's also MRI biopsies. So if a patient has something very, very suspicious, and if the schedule allows it, because sometimes, a patient might come in at a time where the schedule is very full and it's hard to accommodate, then the patient would come back for the biopsy, would be scheduled before they leave. But there are occasions where, if it's like a very large mass, very suspicious and lots of, lymph nodes, sometimes we do accommodate those patients the same day.
So it depends what kind of biopsy they require, and that's how you kind of schedule the patients for their biopsies. Is that correct? Okay.
Yes.
Okay. And so, what are the most common ways breast cancer is detected?
So at age 40, for the general population, it's recommended to get a screening mammogram. And that's sort of the universal guideline in the United States. If a woman has dense breast tissue, and this isn't performed everywhere, so it is location or geographic dependent. Based on the density, a woman can also get screening breast ultrasound, and that can be very helpful. Those are the main ways for, general screening and detection.
And so, if there are patients who are younger than 40, as we see more and more, younger women are being detected with breast cancer, what is your recommendation?
So there are certain populations who have been identified as needing to get screened earlier. And generally, those are women who have a greater than 20% lifetime risk. And that could be somebody who has a first degree relative who's had breast cancer, such as a mother, a sister, or a daughter. They generally, if their relative was diagnosed, say in their early 40s, then it's recommended that they would start screening 10 years earlier than that time of diagnosis. Um, but they would not get a mammogram before the age of 30. So if they were to screen earlier than the age of 30, they would go for a breast MRI. And breast MRIs are starting at the age of 25. That's the earliest that we would start screening a high risk patient. Um, and there are certain genetic um, factors, yes, that would also require that. So anybody who tested positive for the BRCA1 or 2 gene mutation, and then there's some other gene mutations that would give them that greater than 20% lifetime risk. If they know that they're positive for that gene mutation, then they would also be recommended to start as early as 25 with breast MRI. And then once they reach the age of 30, then they could also get the screening mammograms.
I just wanted to kind of put out, what are the options for people to look at, essentially, especially people who don't think, at a younger age that they may be, it's possible
It's a
to get to.
possibility,
Yeah,
yeah.
yeah. So, can you explain the difference between screening and a diagnostic mammogram?
Yeah. So screening is when you come for like a routine appointment, just a yearly appointment. So generally it's for women who are 40 and above, it's, your yearly annual exam. You don't have any symptoms and we're not looking for anything in particular. We're just screening for breast cancer. A diagnostic exam is when a woman comes in for a particular reason and needs to have, the doctor kind of look at the exam and make a decision in real time as to what the next steps are going to be. So, a woman can come in for a diagnostic follow up of something that was seen before, or she can come in for something new, um, basically any reason.
Okay. Yeah, it's just kind of explaining to people that screening is not necessarily your diagnostic mammogram. So, can you give us an example or an understanding? How do mammograms, ultrasounds, and MRIs differ in their ability to detect breast cancer?
So, a mammogram it's essentially an X-ray of your breast, and so it's got kind of that name of kind of like a not very comfortable. So your breast is in compression during that exam for a very short amount of time, and I will say there is a reason for the compression. So basically, when we are taking a picture of the breast, we want there to be as little tissue in between the two plates because if we have less tissue, then there's less radiation. So, the amount of radiation you get from a mammogram is already very small, but we try to make it as minimal as possible. So the compression actually helps to decrease the radiation your breast is getting. So it's uncomfortable, but there's a good reason for it. Um, So the mammogram, it takes a picture, and nowadays a lot of places have something called digital breast tomosynthesis, or DBT. And so that's basically like a 3D X-ray of your breast. So when you're going for a mammogram, you may see the machine going do 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 all around. So it's actually taking pictures all around, and then it synthesizes a 3D picture, which is extremely helpful for us in seeing masses better. We can see distortions more clearly. It really improves the diagnostic capability of a mammogram. Generally, with a mammogram, we are looking for things like, we call them asymmetries or focal asymmetries, calcifications, distortions. These are all things that we can see on a mammogram. And just to kind of give a little background, because I know a lot of the terminology we use is very unfamiliar. An asymmetry is something we see on one view. Focal asymmetry is something we see on two views. So the mammogram, we take a picture where your breast is like this, that's the MLO view. Then we take a picture where your breast is compressed, kind of like this, like a pancake, and that's the CC view. So we use those different views to help localize where things are in the breast. The ultrasound does not use any radiation, and it helps us characterize masses better, especially for women who have dense breast tissue. Sometimes, the sensitivity of a mammogram can actually be significantly decreased because of the density. So the ultrasound can penetrate dense tissue, and it can better see and characterize small masses and lesions that we might not be able to see on a mammogram. We can also see lymph nodes very well with an ultrasound. And on mammogram, sometimes we get some of the lymph nodes and sometimes they're too far back. So ultrasound is very good for that as well. And then MRI it uses a gadolinium-based contrast agent, and it does not have any radiation, but you are sort of prone, or you're on your belly for the MRI exam. You go into the MRI tube, and the sensitivity with MRI is very high. We pick up a lot of things on MRI, but with that comes what we call a decreased specificity. So sometimes the things that we pick up are benign. They're not necessarily a breast cancer. So that's just something to be aware of when you go for an MRI. There's a good chance you may be called back for something with that.
Okay, and I think so. What you're saying is, for someone with dense breasts, an ultrasound is a better option.
So if you have dense breasts, you should get both a mammogram and an ultrasound, because alone their sensitivity is not very high, but together their sensitivity, and mammogram and ultrasound, is over 90%. And then MRI sensitivity is also over 90%. And nowadays they even have contrast enhanced mammography, which is coming out at a lot of places, and that imaging, you also have your sensitivity over 90%.
Okay, so
That's with a dye, with gadolinium.
So the contrast enhanced mammography, it doesn't use gadolinium. It uses a contrast that you would actually get more with like a CT. Only MRI uses the gadolinium-based contrast.
We asked breast surgeons why they trust CubTech for intraoperative specimen imaging.
I love CubTech because of the clarity of the picture, the ease of use, and the awesome customer service.
I really like using the CubTech machine because it gives you a tomo of the specimen. We use tomo for breast imaging. Why not use tomo for specimen imaging?
The Mozart 3D gives the breast surgeon what we need. We need to know, did we take out the tumor and did we get the whole thing? And I use it on a regular basis, the CubTech 3D.
When it comes to specimen imaging, there's only one name you need to know. It's CubTech.
So, what are the signs or symptoms women should pay attention to, even men maybe, that they shouldn't ignore between screenings?
So, generally, for if you are performing self exams, something to look for is, I would say you kind of have to know your breast tissue because a lot of times normal breast tissue can feel a little lumpy and bumpy. But if you feel anything that's sort of hard and fixed, that's usually something to be aware of. Um, if there's any like redness or itching of the nipple, any skin dimpling. So if you perform an exam in the mirror, if you lift both of your arms up, if you have any areas in your breast that are sort of dimpling in, that can be an indicator.
Okay, those are all good suggestions to take. Um, how do radiologists work with pathologists and surgeons?
So we are definitely a team. Um, So radiologists are the ones who look at the images, make a diagnosis, and make a recommendation for biopsying certain things. Once we biopsy it, we send it to the pathologist who looks at it under the microscope, looks at the different cells, and they figure out what this area is. And they basically give it a name like whatever it is. Um, and then if it's benign, then we don't usually need a breast surgeon. If it comes back as a cancer or something atypical, something we would recommend being removed, then the patient would have to go to the breast surgeon for that.
Okay. And so do you also, have a role in sending them to the oncologists?
Yes. Generally, the next step is to see a breast surgeon, and the breast surgeon then navigates the patient to the rest of the process of treatment, and that includes helping the patient make appointments with an oncologist, sometimes with a radiation oncologist if necessary. That's usually where the breast surgeon steps in.
Okay. Okay. So it's first it's you and in some parts the pathologist and then the breast surgeon who then recommends the rest of the plan or the treatment essentially.
Exactly.
That's helpful in understanding, what are
Right.
the different
The
steps.
process. Yeah.
Yeah.
Mhm.
Yeah. So what role does imaging play in determining the stage and type of breast cancer?
So that's actually a question that I get a lot. Once I let someone know that they have a breast cancer, they always ask me, what stage is it? And um, given just a breast biopsy, we're unable to really say the stage. The stage is based more off of the biomarkers and other imaging, making sure that the lymph nodes look okay, making sure that no other areas of the body are involved. So that is sort of how the stage information is gotten. Most of the time, I wouldn't be able to tell a patient their stage.
Do they need to get like a CT scan or something for that purpose?
It depends. So it depends on the type of cancer. It depends on the biomarkers, and it depends also on the symptoms that a patient might have. So they don't breast surgeons don't routinely order CTs or PET scans, but if it's indicated from other factors, then they might they might want a patient to go for the additional imaging.
Okay, got it. How does imaging guide treatment decisions for breast cancer?
So generally, we kind of help the surgeons decide like the extent of disease. So you know, if we only see a small area that's involved, Usually a surgeon can just remove that area like a lumpectomy, so it's a very localized treatment. If we see lymph nodes that are involved, the surgeon would definitely want to take out some lymph nodes to make sure that they're okay. Um, and then sometimes, with breast MRI, we look at other things like, is there any involvement of the chest wall or the skin? And so we can help guide the breast surgeons in knowing exactly how much needs to get removed.
I have a kind of a question where patients have asked me this, and I'm not sure what the answer is. And the question is, if I'm being X-rayed, how much of that gets collected in my tissue? How much is the X? How many rads is it?
So, the amount of radiation that you get from a mammogram is actually similar to walking around outside for a few days. Um, it's it's almost just a little bit, I would say, above background radiation that you get. In terms of the exact amount, uh, I'd have to go back and look that up.
Once they have been diagnosed and they've been prescribed a treatment plan by the breast surgeon, how do radiologists monitor response to treatments like chemotherapy, targeted therapy, or radiation?
If a patient has had something called neoadjuvant chemotherapy, that's usually, before the patient has had their surgery, they might go for chemotherapy. So before the patient goes for surgery, they usually have them come back to repeat their imaging so we can see how much the cancer has shrank after the chemotherapy and make sure that their treatment is working. Um, and then in terms of, if the patient has had their surgery, has had their radiation, we do continually look at those areas that have been treated and make sure that there's no recurrence and continue to monitor the patients because once you get diagnosed with breast cancer, you are considered to be high risk. So we're always a little bit more cautious with the screening.
So, do you also have a role, in imaging, in ensuring the surgery removes all of the tissue that is cancerous?
So we do also place what are called seeds, and it's different everywhere. Some places have radioactive seeds, some places have magnetic seeds, some places actually put wires, localization wires. So, as radiologists, we do those procedures to help guide the breast surgeons during their surgery. Usually, they have a probe and they use that to find the seed, and within, you know, um, the seed is the area that they need to remove. So sometimes we have to place multiple seeds depending on the extent of whatever needs to be removed. So it helps the surgeon sort of know what is the area and how big the area is that needs to be taken out.
So they can clear the margins, is what you're saying.
So the margins are going to be more like the after the surgeon removes the tissue, the pathologist is going to be able to tell the surgeon the margins.
So, after surgery, how often do patients need follow up imaging?
So I would say this is also something that differs depending where you go. Some places they follow patients up to 2 years. Some places they just do one follow up after surgery and after that return to screening. So it can depend.
It depends, it's individual essentially
Individual and where you are.
in your journey. Okay. And so, I think, we're about to wrap up. So I just want to ask you if you could give one message to women or men listening today during Breast Cancer Awareness Month, what would it be?
I would say definitely go for the screening exams on time. And, you know, I know that it's hard to say, like, don't be anxious, but I would just say that it's an important thing to do. And then whatever the results are, you just have to take it one step at a time. And it's better, I think, to know than to not know. And there's also very good resources. If you have any questions, I mean, there's this one website called breast360 .org. And, I think it's a good resource to help answer a lot of questions. And definitely talk to your doctor if you have any questions or concerns. But I think, we have a privilege of having this available to us, this screening, because unfortunately, breast cancer is very common. It's one of the most common cancers in our society. So I think having this ability is a really good advantage to have, and we should all try to make best use of it.
Well,
Great.
thank you, Dr. Sharma.
Lots of good information. Lots of good information. I appreciate it. Thank you.
I appreciate getting the opportunity to talk. So thank you so much.
Today's discussion with Dr. Puja Sharma has highlighted how vital breast radiologists are in every step of the breast cancer journey, from the very first mammogram to guiding treatment and supporting survivors. I hope this series will not only educate you, but also give you a sense of empowerment, that early detection matters, that treatments are advancing every day, and that no one has to walk this path alone. Thank you for joining me on this journey. Please share this episode with someone you care about. And don't forget to subscribe to the Mood Food Podcast for more conversations that nourish the mind, body, and soul. Until next time, stay informed, stay strong, and remember, awareness saves lives. Thank you.